You're listening to Stellar Success, Leveling Up for Medical Pros with Dr. Tudor Francu. Join us as we explore how medical professionals can achieve stellar success in all areas of life. It's time to level up.
Hi, Kelly. How are you?
I'm well, thanks. Thanks for having me.
Thanks for being here. Why public health?
Well, I made a transition to public health after a long career in hospital-based medicine as a disaster and trauma specialist. I felt fundamentally like I was able to make a bigger impact by treating larger numbers. It was a sort of a transition over time. I first became a disaster specialist and then a mass casualty specialist. So it occurred to me early on in my career that I and others had gotten quite good at taking care of traumas in ones and twos. If one or two people showed up in your emergency department, we were quite adept at knowing what to do. But what happens when it's 10 or 15, or God forbid, 50 or 60? So I started looking and saying, how can we do this better? How can I learn to do this better to manage large groups, mass casualty? And there are people around the world who are very good at it. The Israelis, for example, are very, very good at understanding how to manage mass casualty. So that's really how it started. And then I transitioned over time towards more public health, more population-based health management. I ended up taking over a company that managed healthcare for the employees and their families of Fortune 500 companies. So companies like Continental Airlines and Nissan Automotive, Sprint, those sorts of companies that had thousands and thousands of employees, and was able to apply what I knew from, single medicine, hospital-based medicine, to large groups, large populations, and to design and implement then programs, both medical programs and health and wellness programs, to help improve health and, as a result, drive down costs.
Yeah, it's very interesting. I have to be honest, I'd never had a guest in my podcast with your breadth of knowledge treating mass casualties. And I want to know, what do you think is the main mindset change for you to think from, one single hospital and come back to a bigger perspective, with treating many, many patients at the same time? Like in, an event like that, God forbid.
Yeah, I think it's really fundamentally about resource management, understanding where to put your resources, where to deploy resources, and how to split up your most skilled people so that they can treat the greatest number. Fortunately, we have the ability to work now with what we call ancillary healthcare providers, whether those are nurse practitioners or PAs, surgical assistants, and so they have helped to extend. They've become physician extenders. So for every one physician, you might have 3 or 4 ancillary healthcare workers or physician extenders, and it's understanding how to really manage those resources, where to place them, and also how to manage the other things you're going to need in the time of a disaster, whether that's generators, fuel, security, those sorts of things. So it really means sort of having a very, very broad purview, looking at any particular situation, disaster, mass casualty event, getting triage in place very, very quickly so that you can determine exactly how many patients you have in every category, meaning those people who are critical but potentially salvageable, those people who are the walking wounded, and those people who have minimal or no perceivable injuries. Triaging those people very quickly and then getting them deployed to as many potential facilities as you have available. It really, there's absolutely a science to it. You certainly can't summarize it in just a few minutes.
I realize this is such a bigger perspective and an issue, and it's. I'm thinking of it like more like a FEMA at a smaller scale,
But how absolutely.
How do you prepare for this? How do you do I don't know, mock trial,
Well, for example,
or something
yeah,
like that?
well, for example, I spent many years teaching an active shooter preparedness and response course aimed towards municipalities and working very closely with first responders, meaning police, fire, rescue, and everybody in between, where we actually did practice, where we set up scenarios, where we would do mock shootings and have 50 victims and get them triaged. First of all, get them out of the area to a safe space. So actually rapid extraction, teaching, and it's one of those things I would say that the reason that training and practicing in actual scenarios is so important is because you don't want to be exchanging business cards when the bullets are flying or when the building is burning. You need to know. And what we've learned over time, I really became a student of disasters, starting back with Columbine, that's the mass shooting that most people can first remember in Colorado, in Columbine in 1988. And that was a very, very mismanaged, unfortunately, tragedy because we didn't have the mindset of getting people out of the building quickly and of stopping the threat, meaning that the first officer who arrives needs to eliminate or stop that threat. And what happened at Columbine was that they waited for a long time for reinforcements to show up, to wait for the SWAT teams, to wait for other law enforcement. And as a result, tragically, many of those children were salvageable from a trauma standpoint, but they ultimately bled to death. And that I found very, very troubling. And I said, we can never allow that to happen again. So we began really training and practicing how to quickly eliminate the threat and then get patients, victims, out of a scene to a safe place and rapidly to triage. There's the time to get somebody who's a victim of trauma, whether it's a shooting or other trauma, to get them to a hospital, to a surgeon, and whole blood is the difference between survival and not. So it really is about training and doing it not just whiteboarding, not sitting around a conference table and talking about how you do it, but actually, in a school, in a mall, we've done these exercises, 3-4-day exercises where we actually have used abandoned shopping malls, schools, churches. We go to places where these things are likely to happen. And the interesting thing about training for active shooter is that about 90% of what we teach and train for how to respond is applicable to other scenarios, other disasters, meaning a wildfire, a tornado, a flood. So if you train for the active shooter, I think that most people can take away the physicians who are there, the law enforcement who are there, other first responders, whether it's EMS, fire, rescue, whoever it is, they can apply those lessons learned to almost any mass casualty disaster.
This is a Stellar Success podcast, and this is not an area where failure is an option. Mm-hmm. What do you give as an example? And I'm sure you had probably setbacks and things that didn't work well in your experience throughout your life and dealing with these issues. Any examples of that was something that didn't work out? And you learn from it, and you applied for the next round.
Well, there's no question that, sometimes things do go sideways. You can practice and practice and practice, and then when the real thing happens, it just doesn't unfold the way you imagined it. And we see that, unfortunately, many times in these active shooter scenes where law enforcement end up getting injured or shot themselves, or we are not able to salvage the number of people that we thought. I could tell you a great success story. we taught an active shooter course in southern Colorado, in Montrose, Colorado, a little small town near the ski town of Telluride. And we taught it over 3 days, long weekend, as we always do, all about how to respond to an active shooting scene and how to get victims of that out of the area and sent out to various trauma centers, deploying everything from helicopters to ambulances. And 2 days after we left, there was a tragic mining accident in that small town in Ouray, where they've got, 2 police officers and a volunteer fire department. And they managed to show up and extricate 30-some victims from that mine shaft and get them sent out to hospitals all across the state in a matter of literally a couple of hours. I think they had a total of 2 or 3 deaths total. And they were asked on camera afterwards, they said, how in the world did this tiny little town with a volunteer fire department, and 2 police officers and, sort of a Forest Service guy manage to pull this off? And they said, because we had just done an active shooter training. We just had all been together for 3 days, understanding how we would work together, how we would have our unified command system, how we would, communicate and how we would structure it. And they managed to apply those lessons learned to another totally different disaster. And they performed remarkably well and undoubtedly saved dozens and dozens of lives as a result. And those are the sorts of success stories that make you want to keep going with this. Tragedies.
It's something that, it happens more and more these days. And I feel like people are not prepared for this. I feel like hospitals are not prepared for this. It's one thing to deal with mass casualties for a level 1 trauma center that is used to see those like every day, and the physicians know what to do, the staff knows what to do. But when you deal with this kind of situations day in and day out, it's easier to deal with a mass casualty event. What happens with the smaller hospitals? What happens with the staff in general, with the I would say the general surgeon or ER docs that are on staff and on call that have probably never encountered a scenario like that? How do we spread this to as many people as we can?
Well, unfortunately, you are quite right. And I've said for my entire career, your likelihood of surviving a particular trauma is directly related to your proximity to a level 1 trauma center. Because as you said, some of these smaller rural hospitals may never have seen a gunshot victim. They may never have seen a burn victim. So generally what those hospitals are trained to do and what they're very good at doing is stabilizing the patient and getting them the heck out of there. They need to get them transferred, and they are very good at that. They know that. They know as soon as they see a trauma patient or a burn patient or a gunshot that they are going to need to stabilize them, meaning start multiple IVs, do whatever they need to do to resuscitate the patient immediately, but then as quickly as possible get them transferred to a facility that has not only the surgeons and the training and the capability, but the facility to do it, the operating rooms and the types of equipment that you would need. So unfortunately, many of these are just stabilize and transfer, but they're good at that. And the network of hospital systems, I think, is far more advanced than your average layperson understands. Those smaller hospitals are in contact regularly with their local, sort of big brother. They know where their, closest burn center is, where their closest trauma center is, where their closest cardiac cath labs are, and those sorts of things, so that they know exactly where to send those patients. They employ, obviously, both ground transfer by way of ambulance, but also both helicopters and fixed-wing aircraft to get people transferred. And that happens. I live in a relatively small town in northern Colorado, and unless you have an orthopedic injury, you're going to get sent out somewhere else, down to Denver to a bigger center. So we're very, very familiar with it, even up here where I am in Colorado.
Now, in terms of your personal I would say, routines and mindset to deal with this kind of issues. What do you personally do to kind of deal and spread the educational part of it with people in your circle? What do you think is the best strategy to do that?
Well, I think I have a very, very close network of people who are trained like I am, and the people who I've taught with, whether it's active shooter or any other mass casualty training I've done. We work very, very closely together, both to manage the stress of these sorts of situations, but also to pass along best practices. I now have transferred. It's interesting, during COVID, all of a sudden the interest in mass casualty and active shooter and everything somehow disappeared. All of a sudden it became all COVID all the time, and I transferred much of my time and energies towards the pandemic and the public health response, which, by the way, was quite horrific to that pandemic. And I've spent the last 5 years really, really focusing on that. It's almost as if we can't manage to do more than one thing at once in public health. So right now it's all about pandemics and vaccines and cleaning up the food system rather than focusing at all on mass casualty and trauma. But all it takes is one, series of flooding disasters, in Tennessee and North Carolina and Texas to bring us back to understanding how important it is to do that training. So I have had the opportunity to really spread my interest and to spread my public health focus across not only the disaster and trauma piece, but also, as I said, onto this more recent disaster of the pandemic and the way that it was managed from a public health perspective. So I keep my finger in all of those things. It keeps it interesting.
Yeah, absolutely. I think it's just a matter of time for those things to happen in different areas, either the next pandemic or the next shooter or the next, disaster, natural disaster. And I feel like people don't have enough knowledge and education to deal with this from the medical point of view. I'm talking about, and I wish there would be a training program for, emergency room physicians or emergency room staff to deal with this type of issues in their communities. Let's say, the recent flooding that happened in Texas, right? With all that, the camp that was basically wiped out in a single night. That community hospital was never encountered something like that in their life.
No, and you're exactly right, because even the best emergency department, the best level 1 emergency department, we think back to some relatively recent disasters up at, the Boston Marathon bombing, for example. You're in Boston, where they have a, plethora of excellent hospitals. They have multiple level 1 trauma centers, very, very close by, but they were very quickly overwhelmed with patients. It's an all hands on deck. You've got to call in everybody, even people who are not on shift or not on call. You're trying to get extra help, but you could see how quickly even these highly trained hospitals can be overwhelmed. If you take your relatively small, rural hospital, more than 1 or 2 critical patients at a time would be just very difficult for them to manage. And I don't think, I could tell you from myself, I was residency trained in emergency medicine, we did not really do anything related to mass casualty to say, what would you do if there were 6 patients like this, Dr. Victory?
Exactly.
What would you do if all of a sudden, you're good at the 1s and 2s, but what would you do? How would you spread out your resources? What would your plan be? How would you get additional help? What's your first, order of business, 1, 2, 3, 4, in terms of, getting other hospitals on board or whatever in order to manage that? And again, I'm still only talking in the single digits, 6 patients. What happens when you have 50 or 150? And so those are the things I do think we need to think about. And as I said, the Israelis are really, they have it probably down pat more than anyone else because they have a better integration. This is why I believe between their civilians and their military. There's a lot of overlap. The civilians are the military, and there's a lot of overlap in how they work together. So it is easier. I think they find it easier to call in extra help. We in the United States would have a hard time calling in military physicians to a private sector hospital in the time of a crisis. But that really is, I think, the way we would need to think about it in order to have enough hands on deck to manage something.
Yeah, and I think, I wanted to ask you if there is any plan from your point of view to kind of implement some of the protocols that you need to do in this kind of situations, or you can't clone yourself to go in all these places, right? So you need to, do you have any kind of protocols or educational plans to spread the word out and maybe implement some of those protocols to call in, eventually people that are not necessarily in charge with that, but like you said, the military doctors or anybody like that?
Well, it's a great question. I haven't really thought of it yet. I communicate regularly with Secretary Kennedy at HHS, and maybe it's something that I could sit and talk with him about. It would certainly include incorporating FEMA and incorporating all of the resources from the public health system. But I think that it starts with that, and it starts with also doing, as you intimated, training at the residency programs and at the training level to say, how would we actually do this? I think, counting on the government by itself counting on FEMA by itself is never going to work. I think it's largely going to end up being a private sector response. But how to integrate all of these things and to be able to utilize the resources that might be available, say, on the military or the government side, even the private sector side. I looked at a project some years ago when I was doing some work at the School of Public Health at Harvard for how we would use some of the air resources that lay fallow. Think about all the companies out there that have private aircraft, that have helicopters, that have fixed-wing jets, that are sitting fallow, largely not used on any given day. And if we had a mass casualty event, could there be a way to have a registry of all of those, the people, all those companies that would be willing to say, yes, you can use our pilot and our plane to transfer patients from one place to another? Is that something that we could do? Or should we be privatizing FEMA? There's been quite a bit of talk over the years about whether FEMA would be better off managed on the private side rather than through the government, specifically so that they could address these sorts of things, this sort of training and this sort of preparedness, so that we don't find ourselves where we did, for example, with the recent flooding in Texas and a very slow governmental response. It's not what the federal government does best. And I think privatizing some of these responses, whether it's FEMA or the Red Cross or whatever else, might ultimately be the best fix.
Yeah, unfortunately, these days, when something happens, disasters in the world, it's a mass casualty. It's not localized anymore. And I feel the world goes towards that type of injuries in general. Because I'm not sure even if the emergency room physicians training include any kind of mass casualty training in their residency or anything like that. And they go up, they go out and start practicing, like you said, one at a time, one patient at a time. and then, you go practice in South Manhattan or New York, and you deal with a 9/11 type of disaster that you are completely flooded with patients and trauma,
Right.
and you have no plan for it.
Right.
And I don't think anybody can think of what the next mass casualty is going to be, because those people usually that create those type of incidents are evil-minded, and
Right.
you can't predict what they got to do.
Well, right. The other thing that people don't really think about, and I've taught alongside the active shooter course that I taught, we taught a hospital evacuation course. What do you do when the hospital becomes the disaster? What happens when the explosion, the fire, the earthquake hits the hospital? How do you evacuate a hospital that now is no longer capable of treating patients, but was full of patients already, who are already ill or injured? And honestly, you'd be shocked to learn how few hospitals have actually thought through the scenario, what they would do if they ended up being ground zero for the disaster. It happened during Katrina. When Hurricane Katrina happened in 2005, massive flooding, massive power outages, and there were hospitals and nursing homes that needed to evacuate hundreds of patients, some of whom are on ventilators, some of whom needed to be, hand ventilated because the ventilators stopped working and they needed to be transferred to a hospital that had electricity. But it's remarkable how few hospitals actually have gone through that plan and have it as, if they've thought through it, it's in most cases sitting in a 3-ring binder on the shelf in somebody's office. Here's the plan. Unless you have practiced it, there's nothing like that you are going to pull off based on having done a whiteboard scenario or putting together a plan in a 3-ring binder. There's a reason football teams go out, on the field every afternoon and practice the plays, because that is what you have to do to be good at it on game day. And it's the same thing with mass casualty. And hospitals need to think through what they would do if they end up being the disaster themselves.
Kelly, do you do any consultancy work for this type of issues?
I do, and I did a tremendous amount of it before COVID. As I said, it's everything took a back seat once COVID hit. But yes, my primary business prior to this, really for some years, was exactly that: consulting and helping people to understand what their threat assessment is. Whether you're a church, a school, a municipality, a hospital, what is your level of threat from both natural disasters and man-made disasters? People who have malfeasance, what would you do to respond? What is your communication plan? What's your extrication plan? Everything from, your routes of ingress and egress for first responders, all of those things. People and groups really need, churches, for example, have become more and more a target for these sorts of things, acts of violence. And almost no matter where you live in the country, you are at risk from some form of a natural disaster, some places more than others, whether it's earthquakes, wildfires, floods, tornadoes, hurricanes, whatever it is, you have some level of risk to natural disasters. And I really encourage groups to think through this, whether you do it on your own or hire in a consultant, but really take it seriously. And when it comes to children, children, really, even young children, are capable of understanding that things can sometimes go badly, and they need to have a plan for how they're going to behave, where they're going to go. Disaster preparedness really begins at the family level, thinking through a communication plan, an extrication plan, meeting places, those sorts of things. And so I talk and teach about this frequently. As I said, it's what I did primarily leading up to the pandemic, and I'm hoping that now that COVID is behind us, hopefully they won't run the next Fear Fest up the flagpole, and we can start focusing on some of these other things rather than the next pandemic.
Yeah, it's a very, very big problem, and I think it's the tip of the iceberg. We only see a little bit of the actual issue here. And I'm thinking, it's like one of those CIA dormant spies, that they stay dormant for many, many, many years, and all of a sudden they get activated. And I feel like we should do the same thing with this type of approach for mass casualties. We should have some kind of training program for ER physicians or selected ER physicians that are trained specifically in mass casualty approach, and just they stay dormant up until you need them at an event like that, God forbid. And you activate them, but you need to be training them in the meantime, and keep them up with the new things that are coming up. Nowadays, you don't have any more wars, physical wars anymore. You have drone armies that are attacking you. What do you do with that? How do you approach from the casualties point of view? There's so many ramifications of this specialty, and I think, I haven't seen, honestly, anybody who can actually think, like you said, on a family level to teach people how to do these things. Like, we get training of how you resuscitate a kid going in a pool, or, in a fire situation or something like that. But you need this type of training too in the medical world. What would be your advice if you would be in a position of decision-making staff member to approach this in a more organized way?
Well, I think truly that this type of training should become part of the standard curriculum across the board in our society, meaning it should happen in elementary schools. They should have training for disasters, whether it's, hurricane, active shooter, whatever, all the way up through, it should absolutely happen in municipalities. You would be surprised everywhere I teach that law enforcement and fire rescue generally have not done any combined training. It's insane, but it's true. There's no communication. So it needs to happen on every level in our society. Every church should have this training. Every office building should have this training once a year. Every school, every schools, all across the board, hospitals should be doing it. It needs to become part of our mindset that things can go off the rails. Both man-made or natural disasters can happen, and people need to know how to act and how to respond. You're demystifying it in a way because you've practiced it over and over again. Even if you don't get all the parts right, at least you have a place to start. I remember some years ago, there was a shooting at LAX airport, and the first arriving officer was a TSA agent, and the TSA agent had his walkie-talkie, his way of speaking, and the next person who showed up was an LAX police officer who had a channel that did not coordinate with TSA, and then the next people who show up were the LA Police Department, and they had never met the LAX security guards or the TSA agent. So now you've got 3 levels of law enforcement, all using different communication channels, none of whom have worked together, none of whom have any idea how they're going to respond. This is a disaster, and we shouldn't have it. We are so fractionated. So I think if I were in a position of authority and advising, I would say we have got to start to institutionalize this training on every level of our society, demystify it, make it not scary, that it's just part and parcel of what we train, and there's got to be communication and cohesive communication between all of the different levels. If you're going to need them on game day, you better include them in practice, is the adage. So you really need to be on the same level from a communication perspective before a disaster hits. Same thing happened, by the way, at 9/11. The helicopters, there were police helicopters flying around the buildings, could see that those buildings were going to collapse, but they had no way to communicate with fire rescue on the ground. Think about that. The New York Police Department was in a helicopter and could not communicate to the fire rescue
To get
on the
the
ground.
hell out of here. Yeah.
I mean, that's this level of fragmentation and fractionation between first responders cannot be. There's no good outcome. I'm here to tell you, there's no good outcome when that happens. So I think we really need to start including this training at every level, as I said, from grade schools through hospitals, churches, municipalities, office buildings, because it's doing that training and having the communication with your local law enforcement, local EMS, local first responders, having everybody on the same page for how they're going to react, that really portends the best outcome when and if something does happen.
Yeah, absolutely. Kelly, I want to focus a little bit on you and the way you deal with this, because this is a very complex issue. And how do you maintain yourself up to date in this field? It's a lot.
Yes. Well, I read voraciously. And as I said, I have a group of colleagues with whom I compare notes. I am a student of disasters. Every single disaster that happens, whether it's an active shooter or otherwise, we try to look back and say, what was done right? What went wrong? Where did somebody really drop the ball? Where is there a hole? Was it in commonly it's in communication. Commonly it's that people didn't get the message early enough to evacuate, for example, or early enough that the threat was coming, or they didn't heed that threat, or they didn't have good communication in order to, disseminate that information to others. So it's really about doing the critical after action assessment on every single disaster and trauma that happens to say what went well and what didn't go well. And I think this is part of the reason why I think it might be a good idea to privatize FEMA, because I think that we would probably bring a better ability to break these things down afterwards and make sure that we apply lessons learned to the next time. This is one of those where you cannot cover up or varnish things that didn't go well. The only answer is to say, well, that was a huge mistake, or that was a disaster. If you look recently at what happened in this Texas disaster at the Camp Mystic and the tragic loss of life, sounds like it was largely related to a failure for people to evacuate early enough. They did not perceive or understand the level of the threat and waited too long. That's a harsh thing to say. It's hard to say that, but there's only one way to assure that it doesn't happen again, and that's to acknowledge the mistakes that were made, and to acknowledge this isn't about finger pointing. It's about saying, how can we make sure that that never happens again? What safety mechanisms can we put in place? So, as I said, I'm hoping that the entire issue of mass casualty, disaster preparedness and response becomes more, center focused again, because so much, we really lost some time and some momentum because of the COVID pandemic, and because people were singularly focused on that infectious disease issue, or what they thought it was, and our country's abysmal response to the pandemic. So hopefully we can refocus now, and because we are much more likely, in my estimation, to suffer from one of these other disasters or mass casualties than to have another pandemic.
Yeah, definitely. Kelly, you accomplish a lot in your career, and you have reached a point where you have enough wisdom and experience to look back into your own journey Well, what kind of advice would you give to yourself when you started this?
Well, if you had told me, 30 years ago that this is what I would be doing, that I would be teaching mass casualty or disaster preparedness and response, I would have said, no way, I'm going to spend the rest of my life wielding a scalpel in an emergency department. I think the biggest thing is I have had more than, many careers. I spend a lot of my time now doing media. I do a lot of teaching and training. For me, it has been greatly rewarding, and I felt that I've been able to, as I said at the very beginning of the show, to reach far more people in what I've chosen to do in public health than I would have if I just stayed working in a singular emergency department trauma center. Now, I don't begrudge, I spent many, many years there, and I am proud of the time I spent there. There are people walking this green earth today who wouldn't be if it weren't for what unfolded the night they came into my ER. And it was great training. I had tremendously good training in my residency, and then worked at a number of level 1 trauma centers where, I really had baptism by fire. So I would, for me, it's been rewarding to move to the public health sphere, as I said, because I can now pass on what I learned, expand the approach. And really, for me, it was simply having that aha moment one night in the emergency department when we had a handful of trauma victims at once. And I said, wow, this is pushing us to the limit. And I think we had 4 serious trauma patients at once. I thought, what would happen if we had 40, not 4? And that's really what started me down that journey of looking towards mass casualty and how we could have a better response, and the rest is history. So for me, it's been a great journey. I would tell anybody, be flexible and nimble in your career. I'm gathering that most of the people who listen to your podcast are fellow clinicians or physicians. I would say that there are many, many ways to take your career as a physician if you're at a inflection point or at a point where you need to make a decision. Going into public health or into teaching, I think is very, very rewarding if you're ready to get out of hospital-based medicine.
That's awesome. Well, I'm glad you made that change because I think it should be more people like you out there. How can people reach out to you, advice, education, and maybe just start to duplicate what you're doing?
Well, I certainly, you can find my only social media exposure is really on Twitter, X. I at Dr. Kelly Victory. I am currently the chief of disaster and emergency medicine at the Wellness Company, so you can find me there. We're doing really good work. That company was born out of the disaster of the COVID pandemic and the fact that there was so much intrusion of not only the government but insurance companies, politicians, and the media in the sacrosanct relationship between patients and physicians. And so we have really set out to return medicine to be the way it was intended, which is between a doctor and a patient. We make available to people prescription medications that were considered to be contraband during the COVID pandemic, and we allow people to really arm themselves with medications ahead of time in emergency kits, in travel kits, contagion kits. One of the things I have discovered certainly over my many years in not only hospital practice but in doing what I do now is that people are really pretty smart. Even non-clinicians, they know what they need when they need it, and if you give them the medications ahead of time and some coaching, they know when to use them. So people can find me at the Wellness Company as well. And if people reach me on X or on Twitter, I really do try to respond to people if they have questions or want direction with regard to how they would get some training. So feel free to reach out to me at either of those places. And if you're looking for training, again, in disaster management or preparedness and response, whether it's on behalf of an organization or just for yourself as a physician, feel free to reach out to me, and I will do my best to give you direction.
I encourage everybody to look into this topic. It's something that we don't encounter every day. And that makes it even more rewarding, I would say, to be prepared for and to train for it. And I hope, you get out there and more people listen to you. And I really hope that this episode would be listened to many, many people to think, at least, make them think about this.
Yeah, well, for example, I'll tell you, if you're a physician and you know the kinds of things that can happen, and, look in the mirror. If you are a physician whose family does not have a preparedness kit, if you haven't thought about what you and your family, and that includes your pets, would do if you needed to evacuate for whatever reason, where would you go? Where would you meet? Do you have a go bag? Do you have a water supply, food supply, medication supply for at least 3 days, which is the bare minimum? Start thinking that way. Start small. Start with your own family before you think about how you're going to save the world or save your school or your church or your office building. Start small by thinking, wow, what would I do if I needed to all of a sudden, on the spur of the moment, gather up my spouse, my pets, my children, and leave? And, so I tell people there's a reason why I never let the gas in my car get below 3/4 of a tank. I always have cash on hand. I always have a minimum of a 3-day emergency food supply, medication supply, clothing in a go bag. I can pack up and get out of here lickety-split in a New York minute with the people and the animals that are important to me. And I think that that's a good place to start. Your way of thinking about it was with personal family preparedness.
Yeah, absolutely. I mean, things like this don't happen until they happen. Mm-hmm. And when they happen, you wish they will never happen.
Right.
Because you're not prepared.
Right.
And it is something that everyone should think about this. Like you said, not in a end of the world type of way, just like saving as much as you can for like 3 days, like you said, and just, reassess the situation then. But, what if you are in a flooding or a fire or God forbid in a, mass bombing or something like this?
Right. Right.
We don't know what to do. We never been there. We can't train for it. So everybody needs to kind of have that in the back of the mind.
But the places that you frequent, the grocery store you frequent, your church, your office building, I can tell you, those places that I go on a regular basis, I know the routes of ingress and egress. I know, 2 ways out of, the grocery store. I know the doors that lock in my office building. I know, those sorts of things. And it is not meant to be morose or negative. It's simply being prepared. It's playing that what if game in your head. What if, this happened and I needed to get out of here quickly? What would I do? Where would I go? How would I do it? And how would I communicate with my family? Would they know where to meet me? If the wheels fell, if things went sideways, would my children know where to go to meet me? Those sorts of things. It is a mindset. And once you get into that mindset, everything grows from there and you start feeling more, not frightened, it's actually very empowering. All of a sudden you think, okay, I can do this. I can do this, at least for myself and my family. I've got 3 days worth of stuff and we have a plan. We will not, part of the reason, and I'll tell you this tangential to this, part of the reason we teach CPR is not just, the statistics undoubtedly and the number of patients who have cardiac arrest in the field and how many are actually brought back. Frankly, it's very low. But training people in CPR plays another role. It empowers people to feel that they have something they can do. They know how to begin. They don't stand there like the deer in the headlights with no idea what to do. That is a horrible feeling and you never get over it. So part of what makes people resilient, what makes communities resilient, what allows them to bounce back from a bad event is knowing what to do, that they did not freeze. They did not stand there like a deer in the headlights. They had a plan and they practiced it. They talked it through. They had an idea of where to go. And that is incredibly empowering. So when I, leave people after a course or after talking with them, if nothing else, they feel like they have a set of tools in their toolbox, things that they would know, I can try this at least. It still doesn't mean there won't be casualties, it won't be deaths, but at least it helps you to know where to start.
Yeah, absolutely. It's a simple thing like, going to the movies, going to the mall, going to see a concert on a big stadium or to a ball game. Like, there are thousands and thousands of people there. What happened, if something happens there?
Yep.
At least you know the basic stuff to do. Thank you so much for being here, Kelly. I appreciate your presence and your knowledge, and I hope we can maybe continue the conversation at a different national level, I would say.
Yes, thank you for giving me the platform. It's been a wonderful conversation, and I appreciate you giving me the opportunity to talk about it. It's not something that we see covered commonly, so I do appreciate that and happy to come back anytime. And I like the idea of you suggesting that it's time for me to get motivated to bring this to the national level. I'll see what I can do.
Yes, I would definitely follow up with you on that. So I'll keep you on my word.
Sounds great. Thank you.
Thank you.
Are you a busy medical professional striving to excel in life and work? Stellar Success Podcast brings you the habits and insights of top leaders in medicine and beyond. Discover strategies for balance, growth, and fulfillment in every episode. Follow us on Instagram at Stellar Success Podcast for daily inspiration. Start your journey to success today. Subscribe to the YouTube channel now.
That's a wrap on Stellar Success, Leveling Up for Medical Pros with Dr. Tudor Francu. Interested in joining us? Go to stellarsuccesspodcast.com/guest to apply. Stay stellar and level up.